And sometimes what I'll tell you is, on that registry, sometimes you know two things about a topic and you get the question right. This is one of them. Eikenella, I have never forgot that it has bleach odor. It's from human bite wounds. So the clue is there was a fist fight or some reason there was a bite, and you have this in your mouth, and when it grows on media, it forms pits in the media. It like digs little holes in it. They call it pitting the auger. So you know those three things, and it's associated with a mouth flora from a fist fight or a bite wound. You think Eikenella. And the species is Corrodin, so you think of pitting the auger. So sometimes in micro, you might know a couple things and you get the question right, just because it fits those characteristics are so set. So there's lots of different infections out there in the public. In healthcare situations, the hospital is becoming a dangerous place to be. Most people would prefer you to get out as soon as possible and get into your own isolated environment at home because of all that you're exposed to from other patients, from other healthcare workers, like carrying Staph aureus in your nose. So we're going to try to plate your own nose one day and see if any of you have beta hemolytic, the Staph aureus that we've seen this week, beta hemolytic, that you carry. They call it carrying it in your anterior nares. Some people infect patients because they're a worker and then they sneeze or whatever, go clean a drain tube, change something, do something with the catheter, and they give a staph infection to the patient because they didn't know they were carried in their own nose and they sneezed or coughed or did something where some droplets came. The worst case I had heard, I don't know if any of you have ever had the whatever they do to make your vision better, what do they call it, LASIK? Kathy Story is now the head over Christian and Alt Memorial. But back when I started, she was the head of the lab at Alt Memorial, and I dealt with her instead of Ruth. And her and two other coworkers were getting LASIK. The first one, nothing went wrong. Kathy was the second one. She gave herself Staph aureus in her own eyes from her own nose. The first eye they could treat with antibiotics. The second one, I think she had to have some kind of transplant, corneal or something, because of the staph she gave herself from carrying it. And then the third one, I think, opted out of doing it after Kathy had so much trouble. So your infections you acquire in the hospital are scary. My father-in-law had staph in his nose, was set for a hernia operation. So what they started doing, and I don't know when you go, if you can ask in your micro departments, at St. E's, they tested his nose. He was a carrier of staph. So prior to his hernia surgery, he had to do 5 days of antibiotic therapy. So they're trying to be proactive and test patients, especially surgical patients or patients from the geriatric environment. And anything through a catheter, through a central line, anything like we talked, what bacteria did you learn yesterday loves moist environments? And it's patients that are the burn patients that have lost their skin, Pseudomonas. And so a lot of healthcare settings, it's a danger to be in the hospital. There's a girlfriend who, she was very, very heavy, and she developed a sore in her abdomen area that started spreading and going bigger and bigger. So she was in Barnes for probably 6 weeks. And now it's impacted her intestine where she cannot have any food for 6 weeks. She's on a line, a feeding tube, because she would ooze and the lining in the area of the intestine would break and the infection would spread. And all from a sore that got bigger and bigger and bigger and invaded into her intestinal area. And now she's housebound, basically. I mean, she can carry everything with her. She has a home health nurse, she has a wound vac that is trying to heal the wound from the outside in, and it's all associated with the infectious process that she can't eat. The only thing she can have is water, and they just recently allowed Gatorade because that was too harsh on the lining and it was causing it to break open and leak. So it is a scary thing if you get any infection in the hospital setting. This is the part we can control. Aseptic technique. Remember what was the biggest thing you can do as a tech working in micro, that you don't bring anything from the environment to what you're plating. Be picky about leaving your stuff open. Be picky about disposing your loops and using new loops and using them correctly, and don't laying them out, or if they touch something, get a new loop. Because remember, you can't see the bacteria, they're so small, so you don't know what's on it. And then always be a chronic hand washer. That's when I became the chronic hand washer, because we did 12 weeks of micro as our rotation during my year at St. E's, and they told us of a person who got Campylobacter working as a student. And that's another stool infection. It's a gram-negative, a little curved seagull shape, and he must have worked with it, went to lunch and didn't wash his hands. Because back then we didn't wear gloves. We just were chronic hand washers. You better believe all of us, we washed our hands every time we touched anything. So that is your best still. And anytime you go to the dentist, you ever think, I hope they sterilize these instruments well. I remember when HIV became big in the 80s, because when I stuck myself the needle, we didn't know about HIV in 82. It was all hepatitis B, not even C. And that was when they were having people get HIV from their dentist because the tools were not cleaned and sterilized properly. So I think about that every time they put those little, just do the teeth cleaning, because I know I always bleed some when they're digging around or getting the plaque off. So, but what do you think is the other thing about increased use of antimicrobial? How many of you get sick and call the doctor immediately to get an antibiotic? And your doctor will send it out without seeing you. I mean, a lot of people have a direct line to someone that'll give them anything they want. And I go to Dr. Pardo, and she's very picky. She wants you to come in. They want to make sure it's not viral. They don't want to give you something if it's not something like sinuses can be truly bacterial. Bronchitis can be truly bacterial. But if they think it's just the cold that's really bad, you don't want another antibiotic, because that's how things get resistant. And then how many of you stop taking the antibiotic the minute you feel better? I had a girlfriend who you'd open her side door of her refrigerator and she goes, oh no, those were all the antibiotics. Once I felt better, I put them there for another time. That's how things get resistant, because you don't complete what it's supposed to do in that 10 days, or like the Z-Pak is the 5 full days. So sometimes we make our situation better. I mean, we make it worse, sorry. So, now, high-risk organisms, I doubt if most of you are going to be around high risk. We're going to get into the biosafety cabinets and the biosafety levels, unless you choose to work in, like the public health, that might get things sent to them that are the very dangerous threats. I don't think most of you will even get exposed to TB. And most labs will see where you go if they still have a special room and still handle TB, because it has to be ventilated properly. Sometimes they have to get fitted for their own mask for working in there so they don't breathe anything in. Do you remember what was the infective agent yesterday? Within 3 feet, why you got to wear your mask with TB? Droplet nuclei. Okay? So I doubt Brucella and Francisella, if they're going to order those, they're going to order a serology test called a febrile agglutinin, because it's not commonly done in a regular lab, even if they had the media to grow it, and it's a dangerous, more dangerous organism. Anthracis, when we get to the gram-positive bacilli, that you can get it through skin. So you can get anthrax. That's probably going to be your best bet if you got it from skin, that you didn't inhale it, but it got in like an open sore or cut. Let's say someone did it as a danger and put it in and mailed it to you, and you just touched it and you had open cut. That would be cutaneous anthrax, and that's going to be the least deadly. The most deadly is if you inhale it and breathe it in, and that's your respiratory. And then if there's any way it gets in your fingers and you eat possibly, and it gets into the GI tract. So you'll see there are 3 anthrax we'll talk about, and the worst one is going to be the respiratory. Coccidioid is one of those dimorphics, so whoever has that should have had coccidioid as one of your organisms. And HIV and hepatitis, I would probably say hepatitis C is your worst one of the 2 because it can be a carrier. I think 85% of people don't get rid of the antigen. Remember, if you have the surface antigen on hepatitis B, even if you have the antibody to the core and you've had it and you develop the antibody, you're still infected. If you keep that antigen, and the danger of so many people with hepatitis C is a lot of them become carriers and they don't get rid of that antigen and they don't just develop the antibody to C. So I think these are minimized because we wear such proper PPE, and I think we're very aware of washing our hands. HIV, back in my beginning of my career, oh my gosh, you wanted to know any patient that had it. So you double glove and you do anything. So we couldn't say, put a patient's name out there, but we would say the patient's name and blood and body fluid precautions. So we as techs knew that's an HIV person, you're better. But really, that's why you use universal precautions. Then you aren't surprised. So that's why I always say it's your right to protect yourself. Don't let someone, oh, why are you wearing gloves? Why are you wearing goggles? Why are you wearing your gown? It's your right. And really, how do you know what the patient has? When I broke a tube of a knee fluid and it cut through my glove, they knew about HIV then. So I was offered a choice if I wanted to take HIV medicine. But it was a lady who didn't have a history of blood transfusion. She had no history of a lot of illnesses. So what they did is they checked her for HIV, hepatitis, syphilis, and then they did me. We were both all right, and then 6 months later, they checked me again to make sure I didn't develop it. Because why they do it initially is to see if I have it already. Then they wanted to make sure I didn't develop it in 6 months. So that's a little bit of a scary process because you don't know. We've had people when the hepatitis B vaccine was coming out, we had people who had hepatitis B and didn't know it. They didn't have to get the vaccination. Do you remember from serology what antibody do you have if you've had the infection, and what antibody you've had if you have the vaccination? You got to know this for the registry. Hepatitis what? For the vaccination? The surface antibody. Which one is for the hepatitis infection? The core antibody. And then you know you're a carrier if you have the surface antigen and the core antibody. You just never got rid of the antigen and you're infective. Okay? So remember, you've got to know that. So that's one of your viruses on virology that if you're gonna hit it on something, that I would expect them hepatitis. Okay, this was in I got this from the Manucelis book. These WHO levels of risk, and so your DeLost is a great beginner book. Manucelis is awesome, especially when you get to disease states. It is awesome. So I hope if you don't have one, I have one out there. It's just an older version. It is so good when you're looking at disease states. So what groups by the World Health Organization do they determine are high risk? And the one in group 4 was, and I think I put it on your study guide questions on the key. It's a weird, when we get to biosafety levels, it's a Congo Crimean hemorrhagic fever. I mean, something that I've never even heard of till I did this. But these are 4 risk groups by the World Health Organization. So this is going to be a matching, and it's on one of your study questions. So naturally, the lower the number, the less the risk. If you are a group 1 type microorganism, probably something like a Bacillus subtilis, something you might, a Staph epi, are considered normal flora technically. It's a minimal or none individual risk, and there's not a danger for it to spread in the community. When they talk about community risk, is it something like, we'll talk about Enterobacteriaceae family is very interesting. Just in your eyes, it's overwhelming because there's too many genus or genera in it. But one of them that causes plague is called Yersinia, and that would be a very high community risk of spread. Okay, so think of community. Can it spread to a lot of people easily? Okay, so that one doesn't have much risk to you as an individual or to spreading in the environment. Group 2 would be a moderate risk to you, but it's not going to be an epidemic where it spreads to a lot of people because you have it. So it can cause animal or human disease. It can be serious, but you have treatment and ways to prevent it. Think about this. When you get to a group 4, you're probably not going to be able to treat it easily. So think of that. It's not just how dangerous is the bacteria, but can you treat it? Group 3 is a very high risk to you as an individual, but it still won't spread to a lot of people. So in this case, it could cause serious disease, but does not spread from one person to another. So you got to keep in mind, how great is the risk to you individually, and then how great is it to be spread to others. So naturally, the worst one is going to be 4. You can get it easily, and there's a risk of it being spread. So probably anything that you get vaccinated for, is one of them that has the higher community risk. Yes?
Can something be high individual and high community but still no treatment?
It's probably going to be more in group 3, because group 3 still can have treatment and preventive. Group 4, you're probably going to have a hard time not dying from it.
So,
And it may be some of the things that we have vaccinations for that might cause epidemics. Like plague is the one that comes into mind because we hit it in our Enterobacteriaceae. That's probably the biggest one I can think of that will hit in our beginning organisms.
what about like Ebola? Would that be 3?
I don't know. Does Ebola have a great treatment? Can you? I mean, if you can prevent it, it'd be 3. If there's preventive measures and you can treat it well, it would be a 3. I don't know enough about Ebola. Do the people who get it, are they automatically dying?
I don't know.
There's treatment.
Yeah.
They have
There's
vaccine
treatment
now,
and there's
but
vaccine, but it's a high community risk, isn't it? Highly, because it's extremely contagious.
Yeah.
So, at least these are the ones they have established now, not saying they will have a high risk to individual and community and still be able to treat them.
Where would the common cold be in that? Because they don't have a cure technically. Would it be group 3 because they can't?
I don't really consider it, you're eventually at least going to get better from it, even if you don't have a treatment that is foolproof for a cold. I think of a 4, you're not going to get better. There's no preventive, there's no treatment. So cold, and I think colds pass pretty easy to other people. So I think it'd be one of those that you could possibly, you're going to get better and it can spread, but it's not one of their groups they have recognized yet. Not saying they won't come up with one that they say high individual and community, but you can treat. That would be like the 4th, and then 5th would be high individual, high community, and you can't treat. But at least they haven't changed. I think this book is 2015. I don't think they've changed it at least yet. But that would make sense, the ones that are high risk to everybody, but you can get better from them.
So you're not gonna ask us to classify, give us a disease state, say classify.
No, you just have to know
The
if
matching.
it, just the matching on it. Yeah, I'm not gonna have you know more than that. So the biosafety cabinets, they're in, the DeLoss, and I have them on Blackboard too. And I have them in the PowerPoint, they come next. But you have to know that there are 3 that are commonly used out there. 2 is the most common you're gonna see in normal micro labs. 4, they talk about a safety, but it's an entire building that's isolated for just microbiology. And it kind of sounds like getting to me when you're going into outer space, that you have that holding chamber, that you come from the oxygen, then you get into this holding chamber, then you have your suit and all that you put on, and then you go into the spaceship, whatever, that doesn't have oxygen. That's what I think of a type 4. It is a whole environment that is strictly just for contagious things, and you're gonna make sure you have a suit on, you do not wear anything out of that environment anywhere else that you could bring with you. Unless you work in a special microbiology situation where you're working with the most dangerous organisms, I don't think most of you are gonna encounter the class 2 type. So in this little chart, I don't know if I can read it from here or not, but I have the picture in here. If not, we'll put it up on the Elmo. They have a lot to do, they call them engineering controls. What do they do with your room environment that it takes any aerosol away out of the environment so they don't stay harboring and hanging out like the droplet nuclei? So these different cabinets are going to do things with special filters. You should at least know the filter name is HEPA, H-E-P-A, that they do utilize. And so the bottom line, they're going to try to make sure you don't get exposed to a lot of what aerosol could be created when you're working. It's a lot of times you're doing your setups always under the hood. And I shouldn't say that always, because it seems like St. E's, I'll walk in and they have a lot of things lined up on the counter here that I don't think they always bring under the hood. I think you guys did setups there, didn't you?
Yeah,
Do you do
they're-
some on the counter and some under the hood?
No, they just have it set up on
Over
the
there,
counter
but then they
and
bring it under the hood. Everybody should be doing setups under the hood. When you work with the plates, and I will be honest with you, a lot of people do not wear gloves when they work with plates. And Laura said their reasoning was something with, if they wore gloves and touched something, they would know what they're transferring it all over the place. But if they happen to touch them with their finger, they would go wash it immediately and know what they've done. When I did my time at Memorial, those 4 weeks I went off and on, I don't think a lot of them wore gloves working with the plates at the bench. I told her we're all wearing gloves and our gowns and everything, okay? But I want you to see a lot of people when they're working with the plates at their benches are not always going to have gloves on. So I just want you to know you might see that, especially a lot of older techs that have been around for a while. But remember, the environment of a micro room, especially with use of the hood, the whole purpose is to make sure you're not breathing back air that potentially could have something in it. So they're going to have air movement and these filters that help with that. So you're going to have to know primarily Class 1, just examples. The big thing you got to know is Class 2 is the main one going to be used, but at least you should be able to match up an example of 1, 2, and 3. This one, air passes through this filter, and the name is high efficiency particulate air. It passes through this filter before reaching an outside environment. I do not know what environment they hook up to once they leave that room. I don't know if they have a special path like ductwork, like a furnace or whatever, so it doesn't just go up into the atmosphere once it leaves that ceiling. Because a lot of the hoods are set up to go through the ceiling. Even our little hood back there, I can't honestly tell you what is up in the ceiling that it goes through. But I would think it'd be through some pathway like a ductwork, not just up in open air. So this one, it uses an exhaust fan only to move air inward and upward out this filter. Okay, that's type 1. And the pictures kind of show the air movement. It has like little arrows. This is the most common hood used. It pulls it inward and downward by a blower, then passes through an airflow device, then through a filter before reaching the work surface, and then the remaining air goes through another filter, reaching the outside environment. So they do a little bit more with these HEPA filters when they get to level 2. And that's your common, most of your labs, because a lot of places aren't doing TB, a lot of places aren't doing fungus. And those are going to be your big aerosol creators. And then class 3, it's a self-contained. The big thing, class 3, they have gloves. So it almost is like a little spaceship. And they still have the one at St. E's that we had, I feel, back when I was there. So you have this holding area. So you put your specimens in this holding area, anything you want to bring out of the environment. So they use it as anaerobic conditions. We make ours with pouches. They actually use this hood as for their anaerobes. So then they have a holding area, and then when you open, you close the outside door, then you open the inside by using gloves through holes. So you put the gloves on, you're standing on the outside, you put your gloves on, and then you open that door. You can bring media in. Everything is done in a contained environment that has a filtering system through it. So this is going to be anything highly infectious. We use this kind of hood for our anaerobes. But when I went to Memorial, they didn't do an anaerobic hood. What they did is, as long as they kept, I don't know if everybody holds the organism for 48 hours instead of our 24 that we've been doing, but as long as they let them grow for, let's say, full 48 hours anaerobically, which is a lot of nitrogen, no oxygen, then they actually work on them out at their open air desk. And that was something that was new to me when St. E's, we did everything in this hood with no oxygen. So the biggest one is 2. The self-contained with the gloves is 3, and the one just having an exhaust fan and one HEPA filter is 1. So this is the example. A is the class 1. So an exhaust fan, so air moves through the open front. See, it shows kind of the arrows. And then the air is circulated within the hood, passing through the HEPA filter before reaching the environment. So this is what I'm saying. A lot of times you don't get to see where this is going because it's up in the ceiling, but I'm assuming there's some kind of ductwork it's going through. So that's your type 1. B is the most common for microlabs, pulled inward and downward. So this is B. It's inward and downward, and then a percentage is filtered through here before going out through another filter out the exhaust. So this one at least has 2 filters, the HEPA. And remember, that's high efficiency particulate filter. And then this is the one, see where I told you have these, at St. E's, the gloves kind of hang out, and then you put your hands in them, and then you work within it. So this one is self-contained, for very infectious. The closed front contains attached gloves for manipulation on the work surface. And then chemical fume hoods cannot be used in biological safety cabinets, and biological safety cabinets cannot be used in chemical fume hoods. The big piece that makes it a safety is the HEPA filters. and the movement of the air. So if you take anything away, they all have at least one HEPA filter, and they all worry about moving the air upward and outward to get out through the exhaust. The big prevention, not so much cutaneous. You could have a cutaneous infection happen anywhere if you don't wear your gloves and get it in cuts. It's the aerosol. You're trying to worry about stuff that you can't see that you might breathe in. So you're going to have to know on a matching the WHO 1 through 4, and you're going to have to know on a matching safety cabinets 1 through 3, and that 2 is the most common. And HEPA filter is a big key to safety cabinets. And this is just another different picture showing type 1, type 2, and type 3. Like this is usually like a holding area, but this is where a lot of that HEPA filter that'll bring it out to the exhaust, and then that's where the gloves are. And I also put in here descriptors about them. We're going to get into biosafety levels, not just cabinets, but that's where we'll get into this high containment area. So don't mix up safety cabinets with safety levels, okay? That's another thing in Manucelis, and the only thing I want you to be aware of that the 4th level, it's a whole room or building that is only used for those infectious agents. You don't wear anything out of there that you go in with. You have to put on, unless they have a room you change into and you put on their clothing and their suits, but usually it's a whole suit in containment for the worker as well. So I doubt if any of you, I mean, I've never seen even, I guess level 3 places who did TB and fungus had a special room. So wherever you go, they may still, like Memorial has a room that used to be for their TB and fungus, but they do other things in there now. They usually had a contained room, and every person had to be fitted for a respirator if they were going to be doing TB that week. Okay, so you've had the WHO risk. There's 4 of them. You had the 3 biosafety cabinets, and now you have the 4 biosafety levels. Okay, they'll all be matching. So, type 1 organisms are not known to cause disease. You can wear just your proper PPE. You can work at your open bench, and an example would be Bacillus subtilis. So what you did in microlab, if that was your gram-positive that you worked with, I would imagine Staph epi they might have worked with, something that isn't known to cause infection. Biosafety level 2 are moderate hazards. You will use safety cabinet 2. You gotta watch contaminated sharps like your needle sticks, but HPV, HIV, Salmonella is considered a biosafety level 2 organism. So this is the level of danger of the organism. So if that helps to put here, of the organism. So this has nothing to do with the cabinets. This is the level of danger of the organism. Level 3, these are more exotic type organisms. They can be potential aerosols. So you need proper ventilation. Usually it's a room they set aside if they're going to work with TB or fungus that could be aerosol creators. And you need special training, and an example would be TB. Yeah, I mean, the other thing you might want to write next to it would be your dimorphics. Your fungus that are dimorphics. And probably the most common one would be histoplasma that you might run across if you get to do anything. And this one is the dangerous organisms, and this one, it has to be, the biggest danger, it has to be in a separate building or an isolated area, and they use biosafety cabinet 3. And the example they gave in the book was some hemorrhagic fever that I had never heard of. But this is, I can't say you're going to get all these 3 that you'll be exposed to in a regular lab. You know, maybe not so much TB or fungus, but I can't guarantee if some of you get to go to Barnes. I can't guarantee. St. Anthony's is a standalone in South County. They don't have to consolidate with anybody. I can guarantee you won't see TB there and some fungus there. So depending on, I can't say it's Centralia if you'll see something there because they do the micro for Mount Vernon. They're an SSM. So remember, so you got the WHO, 4 levels. Then you got the 3 biosafety cabinets, and then these are biosafety levels, how dangerous the organisms are, the 4 types. So those will all be matching, okay? As far as other dangers, chemical can be anywhere in the lab. Fire, when they used to use Bunsen burners as your heat fixer, that was probably the biggest danger of a flammable in micro. And then, depending on if they had an autoclave or some kind of drying oven, but a lot of times people have that in their cleanup area. They don't have that housed in a department. And then we used to use compressed gases for our hood because we wanted anaerobic conditions. We'd have compressed gas in big cylinders that they would add the nitrogen, and that could be a danger if they're not handled properly. I don't think you're going to see that anywhere. And Barb, big thing with Barb, is the best. She's the best safety officer we ever had my whole 25 years, that I was there. And a big thing is documented training, so you know the dangers for your area. Where's your like if you ever needed to know where our SDS sheets, they're right by the Elmo up top. There's 2 binders of them. In a lab, you are supposed to know where you can access the SDS sheets for anything chemical. What do they have? You should have yearly safety training in the areas, especially your bloodborne pathogens, like your HIV, your hepatitis. And I don't know if any of you in clinical, was there ever talk about this bioterrorism, this laboratory response network? Evidently every lab's supposed to have something set up in case there would be a bioterrorism act. And anthracis is an example of a bioterrorism agent that potentially someone would have to deal with. And then make sure if you're shipping anything infectious, you don't do micro at your facility and you're shipping it, that you have special training that you don't send something incorrectly that someone's going to get sick. So those are just other. Tell me what you know about sterilization, disinfection, and antiseptic. Give me an example of what we do just in our little world here for our lab. So we autoclave, and we use high pressurized steam, and that kills everything, even spores. Tell me what we do in our little world for disinfectants on hard surfaces. We do the 10% bleach. It's better if it's let sit than if you wipe it off right away, but does it kill everything? No, it really doesn't kill anything with the spores, but it's still going to help on most days. And besides your countertop, you got to think about your pipettes, your outer knobs, so of your microscope. So you remember, your gloves are only as good as you use. So really think about that in micro. Never put anything in your mouth for sure, like people who put pens and stuff. But so that is a disinfectant. What did you guys use out in your labs? Did they use the wipes, or did they spray other disinfectants? You did a 70% alcohol. Did anybody else do alcohol?
Those are purple wipes that we use.
And that's what the big thing is in them. Did anybody else use something different besides bleach? I just use bleach because that's what I grew up using at St. A's. Now they do, I think, the big thing, wipes.
So bleach doesn't kill
spores, that's what we use to clean, C. diff, rooms and.
Yeah, the best thing for spores is autoclaving, the contaminated whatever. And I don't think most places let things sit long enough that it would clean any spore. And even alcohol on your arm when you're disinfecting for a blood draw, I mean, that is so minimal what that's gonna help you on bacteria. That's why they go the ChloraPrep or the betadine or the iodine for a full minute. And now I think a lot of them break the thing and they rub the whole minute and then let air dry, and then you do not retouch at all. But yeah, so the best thing for spores is going to be whatever autoclave that. I'm not saying you can't wipe up when you're wiping off, but bleach I don't think has.
Well, actually, you
That-
can autoclave the patient's room, you know, so I guess.
Right,
that's
but
probably
I mean,
the
it's probably as good as they can come up with. Luckily, there's really main two spore formers on bacteria, Clostridium, but C. diff is a Clostridium, and Bacillus. So anthracis naturally would be one. Antiseptic, it's not foolproof either, but it's better than nothing. So all those little pump things are like that on the table. So the best thing is sterilization, and an example that we use is the autoclave for being foolproof. I mean, I don't think most people walk around a lab getting sick, so what we do is pretty good. Like I said, I think I had one sick day that I was really sick in 25 years, and we hand washed, we had no gloves, and we didn't wear gowns, and we mouth pipetted water and saline. So, stick a pipette from a drawer you don't know who handled into your mouth and draw up water and saline. So that was back in our day. Back in our day too, I think someone was remembering that the guy I worked with smoked in the lab. I can't even remember that myself, smoking in the lab. But can you imagine? There's a Bunsen burner and compressed gas, and I'm gonna light up.
There's a tech who, stole from
Has to be an older one, because Tom did forever, the guy I worked with, even when you weren't supposed to. Most of us stopped. Okay, so what are factors that influence killing? Naturally, a big one where you're going to commonly come around is spores, because Bacillus have spores and Clostridium have spores. There's a thing called biofilms, which is kind of scary. That's why I said I went back to DeLoss for the antimicrobial, because they talk about prions and biofilms, where it's like this whole army of bacteria grow and lay harbor like on a hard surface, and it's kind of scary. But our world, we're probably going to encounter spores as our most difficult thing in your common labs. So what the type of organism it is, and what we learned too about a capsule as a virulence factor. They're going to be harder to kill than something that doesn't have a capsule. Same thing, if it develops a spore that can just lay dormant and then become infective later, they're going to be harder to kill. And we have two of those we'll talk about, Clostridium and Bacillus. The number of organisms, did anybody remember which GI diarrhea thing I told you cause more serious infection quickly with little exposure of the two?
coli, was it five?
No, that one you have to be exposed to pretty much. Shigella. And of the two that are dangerous pathogens, Francisella and Brucella, Francisella, you can get it with hardly any exposure. So if you're a hunter handling carcasses and you hardly get exposed, you're going to get it. So those, when it says number of organisms, they're dangerous. Doesn't take much. Shigella doesn't take much. Francisella, that hunter's disease, doesn't take much. Concentration of the disinfectant. If you barely put it on, wipe it off, it's probably not going to do much. That's why in micro, I like to let it sit if we can. Because there'll be more chance of killing off the longer you sit. Like how long did you guys clean the room? Did you let stuff sit in it, or
Yeah.
did you wipe it right away?
No, it has to
Sit
air
a
dry,
certain long,
yeah.
okay. That is always going to be better. So that's what we're talking about, concentration of agent. Organic material. The more blood or mucus or pus, things around it, it's going to be harder to get to and treat. And what is your surface made of? So you got to be careful about things that can absorb. That's why a lot of lab people, since some of them don't wear gloves and we wash our hands, you wouldn't want to wear nail polish. If you're not going to be wearing your gloves and washing your hands well, it can get embedded in your nail polish as a girl, and then, oh my gosh, you can't even get it out even if you go wash it. So if you're going to be someone who doesn't wear your gloves, then I would not wear any nail polish at all, even if it's just a clear coat. And contact time. That's why we try to let ours and micro last longer. Because you know you're working with bacteria on, and I hope none of you put a loop down that has bacteria on it, but how do you know if something doesn't fall out of the bag? And then factors that help, well, I already had contact time on it, but sometimes the temperature helps. If you increase the temperature, sometimes that agent works better. You have to make sure that pH of that, usually if you're buying something, it's going to be at the correct pH because you bought it. Biofilms, this is something, this thing called biofilms and prions are very scary. This are a group of microorganisms, not just one type, that can harbor on a hard surface. So, like a catheter, someone has a catheter inserted them and someone didn't take the proper techniques to clean the patient before they inserted it, maybe didn't keep it sterile before they inserted it. It's a danger when you get a community of organisms. And we had already said more contact time, the better it works. Out of your methods of sterilization and disinfection, the big one is moist heat or heat under pressurized steam. That's going to be your best one. There are filtration methods, there are radiation or using gamma rays. I don't think you're going to be exposed, people using filtration methods or any kind of ray, like they can put a light that would disinfect an area by having these UV rays disinfect an area. I don't know if you'll see anybody that uses either of these two ways to disinfect or sterilize. So for me, the main one you have to know is autoclaving, moist heat or heat under steam. And I think on your study guide, you had to know 2 disinfectants, 2 antiseptics. So I don't care which ones you pick. Antiseptics can be an alcohol, like your 70% alcohol we use when we do blood draws. Another antiseptic could be ammonium compounds that are detergents. Disinfectant, you could use a skin disinfectant would be iodine. If you wanted to disinfect a countertop, you could use formaldehyde. The bleach would be a good one to know. It's a disinfectant that's a halogen. Some detergents can be used as disinfectants. So I think of antiseptics as on the body, and I think of disinfectants on the hard surfaces. So I think you just had to know 2. So I don't care what 2 you pick. Lysol is an example of a disinfectant. Mr. Meekins before me had a bad smelling spray bottle of stuff he bought that we use. But then when I took over, I just switched to what we did at St. E's. But you can, some people buy disinfectants and they use them. Okay, so let's take a 5-minute break, and then we're going to work on that page 35. So how many DeLoss do we have? Because I have 3 with me that we can use if you don't. So who has a DeLoss? Okay. Do you have one, Chris? Yay or nay? Do you have one, Krista?
Yeah, I got one.
Do you have yours, Tashawn? Okay, here, you want to use that one? Who else needed one that didn't have one? You said you had one? Okay. You did, you have yours, and you have yours with you? Okay. All we're going to work on, and there's an awesome chapter in DeLoss called Chapter 6. We're going to do the rest of antibiotics on Tuesday. So I haven't decided what I'll have I might take a few off this worksheet for test 1 and then a few for test 2 to break it up. So go to chapter 6. So what we're going to do is, Laura's coming at 9:30, so we're going to work on this worksheet, and then you're free till 9:30. Okay? So what we're going to do is everybody is going to take one, and it should be chapter 6. If I put my glasses on, maybe I can read. And there's some wonderful blue pages. Maybe I got the wrong chapter.
Page 66.
Okay. So let me show you the great blue pages I want you to use. They're all here. They're page 86, no, page 66 to 67. These blue pages here. Okay, and I'm going to tell you which one you're going to do, and then we're going to go through them, and you're going to tell everybody yours. You'll get a key for the test. But, okay, Lorian penicillins, Leah cephalosporins, and then who doesn't have a syllabus? I'll go copy because you need this sheet. Amanda, aminoglycosides, Patricia, tetracycline, Krista, chloramphenicol, Katie, sulfonamides, Chris, macrolides, Tiana, glycopeptides, Elishaba, quinolines. I want you, skip the miscellaneous, I want you to do antimicrobial agents, and I want you to do an antifungal and an antiviral, the last one. Okay, who needs this to have the key to this up? And then I haven't decided what I'll use of this. Probably at minimum, I'll at least do the penicillins, because that's a concept that we have a lot of resistant bacteria to the penicillin drug. So we might do a couple to split the worksheet for studying. And then we won't officially start lab till 9:30, but if any of you had a gram stain, I would prefer if you get it done before 9:30. That way it can be air drying, and then it'll be ready to go. We can just blot it and see if it's better, because if we kind of want to have the gram stain up with the plates. It all goes together.
When is test 1?
It is every Wednesday. We're going to do, unless something comes up, because then I have Tuesday I can review, and Thursday, if we don't have time to review it, we can at least review it. And then we only have new material on Tuesday, not Tuesday and Wednesday if we had the test on Thursday. Because that's kind of tough. It all starts blending. Okay, so on, let's do it this syllabus. What you want to look for, and this is going to be a matching too, because the bulk of it is going to be on test 2. I might hand pick a couple for test 1, but if you want to put on this worksheet, it'll be, the predominance will be a matching on test 2. And even if I use some again on test 2, it won't hurt you. Because on our unknowns, the first one, we have a book you'll go to and you'll pick a correct antibiotic that is used on the organism you identify. The second one, we actually plate a big plate called a Kirby-Bauer, and then you're going to see how they killed the bacteria. Then you're going to go to the book and look and see if they killed it well enough and you can use it. So even on your unknowns, we build to what you've got to know. And she brought in her book from MDL, and it's great. So you get a little exposure to how to do the antimicrobials. That is, I think, the toughest part for a physician. What in the heck do you treat these patients with when they get resistant? And so we have a big role as microbiologists in the lab, saving him money and time of giving him what really works, because you see what worked on the plates. Okay, penicillins, and this is a great chart in a nutshell. outside of 3 chapters in Manucelis. I mean, that's why I just went back to it. I said, Laura, I gotta get them entry level. I can't make them an expert. I'm not even an expert. Okay, so what I lined it up because it tells you how it works and it tells you something it kills. Okay, penicillins.
Inhibition of cell wall synthesis is the mode of action, and it kills Streptococcus, Staphylococcus, and Enterococcus.
So an example, many times they don't do sensitivities is the term for seeing what antibiotic on streps because most streps penicillin still works. Okay? Cephalosporins.
I didn't know what the mode of action was.
If it is under, if it's, you see under, there's a term called beta-lactam antibiotics. And it says mode of activity. So if it falls in a heading under that,
Okay.
then that's the mode of activity.
Okay.
So it's just another derivative. So that would be your mode of activity, the cell wall.
And then bacteria kills is E. coli, P. mirabilis, Klebsiella.
So what's interesting about that, normally you think of cell wall antibiotics are your gram-positives because they have what? Carbofucin, teichoic acid, lipoteichoic acid. So it's interesting that it does say first generation cephalosporins though. I think I'd want you to know that more. Active against gram-positive cocci other than Enterococcus and MRSA. And then beneath it, it's active against the ones you said. So since it does fall in the cell wall ones, on my key, I'm gonna flag the first line, more the gram-positives. So let me talk to you a minute about this beta-lactam. It's a ring that is in the penicillin drugs, okay? So some bacteria develop an enzyme called beta-lactamase. It breaks down the ring, the beta-lactam ring in the penicillin drugs. So when they say it's a MRSA, that tells me the antibiotic is methicillin. Sometimes they call it an ORSA. Oxacillin is another antibiotic. Now they lump them into one. You do not use penicillin drugs because usually those bacteria that are considered MRSA and are resistant, they produce the enzyme beta-lactamase. So it doesn't matter what penicillin drug you give them, it's not going to work. The enzyme breaks down the antibiotic and makes it ineffective. So one of the things you're going to have to know from me when we start staffs, who are the beta-lactamase producers? And the first one that is known to produce that enzyme that breaks down the beta-lactam ring in the penicillin drugs is Staph aureus. Now, does every Staph aureus produce that? No. But you're going to have to know that for clinical. They're going to expect you to know what are potential beta-lactamase producers. Okay, aminoglycosides.
It interferes with the protein synthesis at the 30S ribosome.
Okay, so more of the RNA or DNA.
Okay.
And think of this, if it's cell wall, you're thinking gram-positives. If it starts acting on protein synthesis, you're thinking gram-negatives. You gotta find another way to attack those bacteria.
And the bacteria that kills gram-positive cocci and gram-negative bacilli.
Anybody know the term broad spectrum? When they give you a broad spectrum antibiotic, it'll kill both gram-positive and gram-negatives.
Right. And they gave Pseudomonas as one of the examples.
Okay. Tetracycline.
It also interferes with the protein synthesis at the 30S ribosome, and it's also considered a broad spectrum. And it does mycoplasma and
Chlamydia.
chlamydia.
And you know what's interesting? I know I've taken tetracycline before, and it was never for chlamydia or mycobacterium. So I find that interesting that that was listed. And I mean, this would have been back in my day that I would have taken it, so it would have been current textbook back then. So, but the big thing, those two were more broad spectrum. You could use it for a gram-positive or a gram-negative infection. Okay, next one, chloramphenicol.
This is one that interferes with the protein synthesis too, but it binds to the 50S ribosome.
Okay.
chromosome unit, and it kills gram-negative infections like typhoid fever.
And so it's more serious gram-negatives. So typhoid fever, if you remember from serology, typhoid fever is by salmonella. Typhus fever is like the Rocky Mountain spotted fever, and it would be on a febrile gluten by Proteus. So they're talking more like a salmonella type infection. Okay? Sulfonamides.
Okay, so with sulfonamides, it interferes with the folic acid synthesis.
Okay, so quite different. So we've had cell wall, 30S ribosomal protein, 50S ribosomal protein, and now we have folic acid.
Right, and this is one is used to treat UTIs, the enterobacteriase.
Okay? Which E. coli causes 80% of them, and it's your main Enterobacteriaceae.
E. coli.
E. coli. Okay? So macrolides or lids.
That's the inhibition of protein synthesis at 50S ribosomal. It goes against two different kinds of gram-positive spectrums. One in the respiratory infections of S. pyogenes and S. pneumoniae. That is in penicillin allergic patients.
So that would be an option for them. If they produce beta-lactamase, they could go to that.
Also goes against mycoplasma pneumonia and Legionella infections.
And have any of you been on erythromycin? I know I have. I would think a lot of you would have been exposed to that, and probably for like a gram-positive infection. Okay, glycopeptide.
This one inhibits the cell wall formation through the inhibition of peptoglycan synthesis, and the drug is usually vancomycin that they use, and it's a gram-positive spectrum, and it treats MRSA and the nosocomial infections.
And that is what I'll flag, is that MRSA. Because remember, if you're a MRSA, you produce beta-lactamase most likely, and you cannot use penicillin. And vancomycin is a last resort drug. So what's becoming scary, and did any of you in chemistry do vancomycin levels? I would think a lot of you would have been exposed to that in your chemistry rotation. That is scary, because if it doesn't work, and there's an organism we've been working with called Enterococcus faecalis, that can be a vancomycin resistant enterococcus. They call them a VRE. So then what do? So a lot of times they give them a combination of vancomycin plus something, because we're running out of new antibiotics. Okay? What do we have, Elizabeth? Benolones?
It inhibits the DNA gyrase activity.
As long as you know DNA activity, that would be what the matching would be under.
It kills enterobacteriase, gonorrhea, Neisseria meningitis, and Catarrhalis.
Probably where I'll
HPV.
flag the Enterobacteriaceae that cause UTIs, because remember the CNA plate? One of the antibiotics that stops growth of gram-negatives, remember only gram-positives grow? One of them is colistin, but the other one is nalidixic acid. And look, that is one of these quinolones. Nalidixic acid can be used to treat gram-negative UTIs. So it makes sense if you put nalidixic acid in the blood auger with another antibiotic called colistin, you're not going to grow any gram-negatives. It kills them. So I'll probably flag the Enterobacteriaceae part. Okay, next one, antimycobacterial.
Those inhibit, they do two things. They inhibit mycolic acid formation in the cell wall and inhibit DNA-dependent RNA proteins. A drug is isoniazid, which
Mhm.
treats TB.
The other one I'll put on your key is rifampin. I told you my girlfriend, I forget who I tell what. My girlfriend was in physical therapy and worked in Alton as an assistant. Started having issues with breathing. Found out she was exposed to a TB patient that was one of their physical therapy patients. Didn't know it till she was trying to out for the state police. She decided to switch careers and they found she had TB from this patient. She was put on 9 months of isoniazid and rifampin. And she was in her 20s when she found this out. So those are the two I'll flag. Okay, to Sean.
Antifungal agents and antiviral agents inhibit DNA activity.
Okay, what antifungal one did you give? I'm gonna give one that is very common. What one did you put?
5-MC.
Probably I'll flag the one above it. The amphotericin B. That is a very common drug for fungal infections. So when you do your presentations, a lot of you will have treatment. One of them will be amphotericin B when you're doing your fungus. What about antiviral?
Amantadine.
Yep, that's the one I'm gonna flag for. You can, if you test positive for flu A and B, especially on a child, they can try to give you an antiviral agent. So I'm gonna flag the one Tashawn said, amantadine influenza A fights. Okay, so, don't worry about doing the gram stain, it's already almost 25 after, but I thought you'd appreciate getting out a little early, so that's why I called to see, are you okay with that? Instead, I know you two have to go pump. No, yay.
I can, yes.
So I thought it would be a little better, we can still have 2 full hours instead of an hour and 45 minutes. And today be the day you want to take some pictures when we get done and review. So you have the plates with what they look like and that. Some of my students also took pictures through the microscope of gram stains. So it's totally up to you. If you want the real gram stain through the scope, they would just put their phone up to through the oculars. So I don't care. And if some of you have great phones, you can share your pictures.